Lawrence. Good morning, everyone. So, Syncope. So, let us talk something about Syncope. Syncope itself is a very exhaustive in itself. So, I will put forth some points to make life easier for all of us who deal with Syncope patients. Syncope patient per se, it takes at least 30 to 45 minutes of my time in my OPD when a Syncope patient comes. So, you have to prepare yourself to spend that much time to find a reasonable diagnosis in any Syncope patient. This patients can't be dealt with in 5 minutes. So, prepare yourself to spend at least half an hour with them so that you can come at a diagnosis, because 30% of the adults will have syncope at least once in their lifetime. Cardiac syncope is a marker for mortality, and then in spite of extensive investigations, 40% of the syncopes will still be undiagnosed. But most importantly, you go back to your MBBS days, you take a proper history, you can come to the diagnosis in 50% of the patients. The key is when the patient reports to you. When the patient comes to you the same day or the next day, you are most likely to hit the diagnosis quicker, faster, and correctly also. So, what is the mechanism of syncope? You know all, ascending reticular activating system, no neurology here. So, that gets compromised by hypoperfusion and the patient loses consciousness transiently. So, what are all the key steps? First is to decide whether is it really a syncope. Second, to come to a conclusion as to what could be the etiology. Third is to decide whether the patient has any other cardiac illness and what is his future risk of recurrence for syncope or mortality. These are all the 4 steps which we need to do when evaluating the patient for syncope. So, whether first question is whether the loss of consciousness is definite, whether it is there or not. Transient, rapid onset, short duration, spontaneous recovery. These 3 things has to be there to prove that it is syncope. So, what is rapid onset? It should be less than a minute. Short duration of the course, which is few minutes, less than usually 5 minutes, and there should be a complete spontaneous recovery. So, these 3 things should be there to say that it is syncope. But the first thing is that to decide whether it is syncope or it is a syncope mimics. This slide is little crowded, but it is an important slide because the commonest differential diagnosis is seizure. So, in seizures you have trigger, triggers are usually present in syncope, that is situation, either blood or smell, which is very rare in seizure. Prodromes are present in syncope: blurred vision, nausea, sweating, abdominal discomfort. They become pale and become flaccid and then fall down. Late myoclonus is a feature of syncope. Very rare to have automatisms. Tongue bites is even rarer. Usually the eyes are uprolled, no postictal state. So, this are the features of syncope. Whereas for seizure, they are cyanotic, they become tonic. Very early in the event, you have tonic-clonic movements and frequent tongue bites, automatisms are there. The lateral gaze is common. You will open the closed eyes, the eyes will be laterally gazed, fixed gaze, sometimes nystagmus may be there. Postictal state is very common in seizures. This slide is very important because the commonest DD is the seizure which you have to differentiate. Then syncope as a cause of TIA, unlikely because the ARAS is situated in the posterior aspect. So, the TIA has to come from a posterior circulation which is very rare because 2 vertebral arteries are there which go and form the basilar artery. Focal neurological deficits, signs like ataxia, oculomotor palsies, nystagmus and pharyngeal palsies will tell us that problem is in the posterior circulation and not a syncope. Hypoglycemia It is not a syncope, it is hypoglycemia coma because it is long lasting. Sympathetic symptoms like tremor, sweating and delayed meals history will be there, and then post recovery confusion is very common in hypoglycemia. Psychogenic, because this syncope happens in young people, you have to be aware of the psychogenic behavioral problems. Multiple frequent episodes, they usually show a slow collapse rather than a rapid fall. It happens mostly when people are around. Significant impact trauma is very rare. Eyes are usually closed, and when you open the eyelid, they spontaneously roll the eye upwards. Lifted limb falls and then stops midair and then falls again. That says that the patient is not fully unconscious. No bowel and bladder incontinence. Recovery is prolonged with no postictal type confusion. So this you have to remember. Cataplexy, it is even rarer, is a manifestation in narcoleptic syndrome. No actual LOC happens. Loss of postural control with unresponsiveness to external stimuli is the clinical presentation. Usually it happens after laughing out loud or cry, and then they will have a slow slump to the floor. That's how the cataplexy behaves. So these are all the syncope mimics which you have to differentiate from a syncope. Now let us look at how the common variety of syncopes behave. So this is a different classification rather than putting it all in list. So the key is low BP. You have to look at the center, low BP and then global cerebral hypoperfusion. The cause could be either low cardiac output or the peripheral vascular resistance is very low. Let us finish the cardiac aspect. Arrhythmia, structural disease and the other causes of cardiac syncope. Next is low peripheral resistance because of autonomic system imbalance. Somewhere in between, a combination of both, you have reflex syncope and then syncope secondary due to autonomic imbalance and then inadequate venous return related syncopes. These are all the how you classify based on pathophysiology. Why pathophysiology? Because this is the only situation where you take history, make a possible link to the diagnosis, physiological explanation and see whether which fits into with the diagnosis. So what are all the historical features which we need to see? What is the position, supine, sitting, standing, activity, change of posture precipitated the event, symptom occurred during or after exercise, immediately or after voiding or during defecation, coughing, swallowing. These are all the historical features that precede the event. So that is very important. What happened the last? And nausea, vomiting, feeling of cold, sweating, visual aura, pain in the neck, shoulder, blurred vision. These are all can happen when syncope. Every history is important because the last half an hour before the event, minute by minute history covering all these points are a must. Noticed after the event, confusion, palpitations, duration of symptoms, headache, nausea, vomiting, feeling of cold, muscle ache, injury, chest pain, inability to stand up without triggering another episode may suggest a neurally mediated reflex syncope. So all these things after the event should be noted. So how to diagnose this? How to diagnose vasovagal syncope? Typical garden variety will be young, emotional people, orthostatic stress, that is most people fall during our anatomy days and school children falling in assembly. These are all vasovagal syncope with autonomic prodromes. What test you have to do is head up tilt test. That will tell us whether the problem is cardio inhibitory, that is bradycardia related, or vasodepressor which is hypotension related. Second common thing is the situation. Situation is when you see blood, when you feel pain, you feel after urination, after defecation, all these are all the situations which can precipitate a syncope. It is similar to the vasovagal syncope. Here historical diagnosis is all that needed, no further evaluation is needed to diagnose the situational syncope. Cardiac, the keys are they usually happen during exercise or syncope in supine posture. Palpitation preceding the event is cardiac. Family history is very important of sudden cardiac death or having channelopathies, having inserted an ICD earlier generations. Yes, cardiac favors cardiac etiology. ECG will tell us, give us a lot of clue. Complete heart block, Mobitz type 2 heart block, 6 sinus syndrome, alternating right left bundle branch block, NSVT. You have an intravascular conduction disturbance with QRS more than 120 milliseconds, pacemaker malfunctions, QT prolongation, epsilon wave, all will give us a clue that this could be a cardiac illness. The echo will tell us whether there is any aortic stenosis, left ventricular dysfunction, old MI, or a structural disease which can precipitate the cardiac event. Orthostatic, the commonest thing is that history of antihypertensives and diuretic, sudden change of posture either from supine to sitting or supine to standing or sitting to standing or prolonged after prolonged rest will be diagnostic of orthostatic. So this will also be diagnosed in a head up tilt test. A drop in BP 20 systolic and 10 millimeter diastolic is diagnostic of orthostatic hypotension. Next is a carotid sinus syncope. Typical history, the shaving induced syncope. You have a carotid sinus sensitivity testing. A prolonged pause will tell us that the diagnosis is a carotid sinus syncope. Beware, before doing a carotid sinus sensitivity testing, that you have to auscultate for bruit because you can precipitate a stroke if there is a plaque sitting there in a common carotid artery. In younger people, you have two diagnoses which can come. Very young people, breath holding spells, which is very common in the age of 6 months to 2 years. Pretty rare after 5 years, usually they abate. The only child, the usual story is there is a cry, there will be an apnea, then followed by cyanosis, myoclonus, and profound limp of the body, approximately 1 minute. Then the child automatically gasps and then comes back to life. So it is a breath holding spell. Usually what is suggested is counseling. A sharp pain given during the episode cuts short the pain, the entire duration of the pain, and the child will recover quickly. The other thing is you have to remember in young people is the reflex anoxic seizures. Normally less than 2 years of age children will have it. Sudden startle or an injury will precipitate this event. Apnea, no cry, loss of consciousness, but rhythmic writhing like body contraction, recovery. But during the episode, they may have bradycardia or asystole also, but usually they settle. You need not put a pacemaker. Most children recover when they are reaching 4 to 5 years of age. So these are the DDs which you have to come to a diagnosis in history and the appropriate examination. Miscellaneous causes which you should not forget is aortic dissection, pulmonary embolism, atrial myxoma, and Al-Kappa. Today morning, I missed the session because of a pulmonary embolism related syncope today morning. So it's pretty common. You just have to look for it. Coming to investigation to confirm our diagnosis, ECG is a must for all. And the diagnostic yield is about 5 to 7%. Multiple ECGs or an event recorder will increase the yield by another 3-4%. Echo, nowadays I say you have to do an echo compulsory because even me included, our auscultatory skills have gone down drastically. So better get an echo, make sure that it is a structurally normal heart. Tilt table test. It differentiates between vasovagal syncope and orthostatic hypotension and the postural orthostatic tachycardia syndrome. In vasovagal syncope, like I said, it differentiates between vasodepressor versus cardioinhibitory etiology. Holter test or a loop recorder or implantable loop recorder. If at all you consider a possible arrhythmic origin of syncope, you use it. Differentiates between epilepsy and uncertain fits, because even after detailed history, there will be particular percentage of patients where you still can't come to a diagnosis. In that cases, yes, it is useful. ILR can be implanted up to 36 months. EP study, it is done to check the integrity of the His Purkinje system. Whenever there is a bifascicular or trifascicular ECG, you check the His Purkinje integrity. Whenever the HV interval is more than 70 seconds, then you have to implant a pacemaker. Second thing is that whenever a palpitation preceding a syncope, we don't know the arrhythmia that is causing it, then you characterize by doing an EP study. Neuro evaluation, it's a predominantly a cardiac disease. It is not needed in a typical vasovagal syncope, but when the clinical history is not conclusive, imaging and EEG are suggested to rule out complex partial seizures and psychogenic behavior. And in children, when the history or the bystander story is not clear, then complete sake you do a neuro evaluation, which will include imaging also. So this is a long list of for syncope recurrence or life-threatening consequences. We all know it. When there is a history of sudden cardiac death, when there is a channelopathy, arrhythmogenic ventricular dysplasia, and history of migraines, structural heart disease, Parkinson, epilepsy, migraine, diabetes, alcoholism, drug abuse, this will portend that there is a risk for death or future events that can come in syncope. So this is in ER. Whenever these things are there, you have to admit the patient for further evaluation. Sudden cardiac death, hypotension at presentation, older age, heart disease, ECG showing abnormality, all this will tell us the patient has to be admitted for further evaluation. Low risk patients, less than 50 years, no cardiovascular disease, no ECG abnormalities, you can evaluate them leisurely at your pace. So, in essence, syncope, initial evaluation should include a history, physical examination and ECG. Initial evaluation is clear, no additional evaluation is needed, all that you have to do is treat. Whenever initial evaluation is unclear, you do blood testing, targeted blood testing. If you are suspecting CAD, you can do troponin and all. Initial evaluation suggests new orthostatic hypotension, so autonomic evaluation is indicated. When evaluation suggests that it is a reflex syncope, you do a head-up tilt testing. Cardiovascular abnormalities, then do a stress test, transthoracic echo, EP study, MR or CT to identify the scars in the LV myocardium. So then you can do a cardiac monitoring to decide whether the patient needs a pacemaker or further EP study is needed. So this is how you proceed with whenever you encounter a patient with syncope. Thank you.